Two, one, let's go. Hi everyone. So I'm Manan. I'm a consultant psychiatrist. I'm based in London. Today I've got someone who's busted a lot of my own myths as far as the CESR pathway is concerned. We've got Sharath with us. Welcome, Sharath, and thank you so much for doing this on such short notice. Congratulations first of all on getting your CESR.
Yeah, thanks a lot. So, yeah, I mean, it's still sinking in, to be honest, because I just got my outcome on Thursday evening. So I'm still having that butterfly sensation in my stomach, and yeah, but it's settling now.
Good.
So yeah, I think thanks a lot.
I'm sure you've worked really hard on your portfolio and to make sure that you've gotten where you've gotten. Today, the main reason why I thought that it would be really interesting, guys, for us to have Sharath on the podcast is two things. A, he has done CESR in a reasonably quick timeline. He has just, like he said, very recently gotten his CESR outcome. So there will be a lot of learnings as far as, people who aspire to do CESR and people who are consultants in their own right and advising people with regards to CESR as well. One of the things that we would want to cover, like I said, is CESR without MRC Psych. He doesn't have MRC Psych, but he's gotten CESR, and that too reasonably quickly. So we would love to learn about that from you, Sharath. We'd love to learn about the whole CESR fellowship that we discussed as well. So tell us a bit about your journey as far as your career is concerned. When did you move to the UK? When did you train, etc.? And then let's pick it up from there, if that's okay.
So yeah, I mean, I completed my MBBS in 2012, and then it was back in India, and for 2 years I had to prepare for the All India entrance exam to even crack. And then I took up MD Psychiatry, and I completed MD Psychiatry in 2017.
Right.
So after that, I worked as a psychiatrist in a program called District Mental Health Program. It's a central government-run project, and I was with that program for 3 years. And in October 2020, I moved to this trust, CNTW Trust, to this place where I'm currently living, which is Carlisle. As a part of a psychiatry fellowship program. So this program allows the trust to employ psychiatrists who have not completed their MRC Psych, and who can provide the GMC registration bit, or the help with GMC registration. So with that, I did come to UK. So that's my journey. And from 2020, of course, initially I had no idea about, how to go about. It took me at least 3 months to even understand how the NHS works. And I was in a psychiatric intensive care unit. So it was a bit difficult because I had not seen patients being that aggressive back in India in my practice. So that was something which was also quite overwhelming. Luckily, the associate specialist working there as well as the consultant working there were quite helpful. They helped me understand how the system works, and all the Mental Health Act related work, like section, tribunals, presenting evidence, writing evidence, all that. And with that, in Jan, like all the other international medical graduates who come, it's time to look at what to do, how to go about with next step. So initially I thought that, because I forgot to mention that, I actually attempted MRC Psych, but it was in 2015. And I had cleared my papers, and I took CASC twice in UK in 2016, but I was unable to, clear the CASC. And because of that, I was a bit skeptical to restart the entire journey once I'm in UK. Most of my friends, they rightly took the MRC Psych, and now almost all of them are in higher training. But there are some who also decided to, do their Section 12, do the ACRC portfolio, and become an associate specialist or innovative consultant within the trust. And the third option was, of course, the CESR. And we had 2 or 3 consultants working within this trust who had completed CESR. So I started contacting them. and asking them that, is it a good option? How do we go about with it? And in 2021, somewhere mid, I decided that yes, I think I should inform my educational supervisors that, because I was in a fellowship program, it's a quite protected program for international medical graduates. I informed them that, I'm thinking of doing this. This fellowship program was actually started by, and the director of it is Dr. Neeraj Berry, who's also the Associate Dean for the CESR, current Associate Dean from the Royal College. So he had designed the fellowship program in such a way that we will get a lot of evidence which we can use in case if we decide to apply for CESR. So that was like a blessing in disguise for me. So I was with this fellowship program for 1.5 years. And during this, the trust itself arranged my short case in CBT, my long case in psychodynamic psychotherapy. I was part of audit. I was given the opportunity to complete my section 12 because I was working in an intensive care unit. And the other thing was they helped me with my 360-degree appraisal. So the things which take a lot of time, I had already done it by mid of 2021. And then I started contacting the CESR tutors within our trust because the fellowship program in our trust was quite, I had heard a lot of good things about it, quite supportive staff as well. So I contacted them, and unofficially I was in the CESR program from Jan 2022 itself. And officially after, the recruitment process, I joined it in April 2022. So because, and as part of this deal, I had 2 educational supervisors. I used to meet them monthly for 2 hours. And I had a clinical supervisor whom I used to meet fortnightly. Again, it was purely to discuss CESR related evidence, how to collect it and things like that. I had a good 3-day induction program about CESR. Each HLO was dissected, how to collect evidence, how to triangulate evidence and things like that. So in a way, a lot of support came in. And because one of my CESR tutor is also a CESR evaluator, so she has done multiple, in fact, many evaluations, and she was also the part of the committee which prepared the 2022, specialty specific guidance for general adult psychiatry, and I was doing it in general adult psychiatry, so that again helped me a lot. And when I started doing this, then somewhere in, I think, early 2023, we were told that CESR will now be changing over to something called as portfolio pathway. And this actually caused a lot of intensity, anxiety, in me and other CESR fellows who were actually preparing. And we didn't know what the new, the specialty specific guidance will look like. And we had dissected this guidance a lot with the help of our CESR tutors. So my initial plan was to submit it in April or May 2024. But I had to speed up the process because November 30th, 2023 was the deadline, and I had to submit it before that. So I just spoke with my educational supervisors, and they decided to go through my entire collected evidence. And one of the CESR tutor prepared a timetable for me on how to go about with how many cases I have to do per month. And also for me, as you said, I do not have the MRC Psych. So I had to collect evidence of child psychiatry, old age psychiatry. I had to do a lot of core competency skills like ACE, and I had to do direct observation of procedural skills, of doing a physical examination, doing an ECG, collecting blood. So yeah, and so with that timetable, I just stuck to the timetable. And in October, early October, I was able to push my application, but I continued collecting evidence because once you submit your application, you can still continue to collect evidence till the GMC gets back to you, assigns you an advisor. They'll get back to you, and they'll also say that I'll keep your all application open until you do these necessary changes. So I continued collecting evidence, and in January, mid of Jan, I submitted to the GMC, and GMC advisor said it's totally fine. I'll ask my supervisor to go through it. And February 19th, to be specific, it was submitted to the Royal College. Interestingly, previously all those who have submitted would be on a waiting list. For me, luckily, they said there's no waiting list. You're directly, once you submit, it goes to an evaluator. And I got my outcome, as you know, on May 9th of this year. And when I looked at the evaluation form, which you get as part of, the email which you get that you have, congratulations, we have approved your portfolio. The sign from the Royal College is of 10th of April. So February 19th to 10th of April is the time taken by the Royal College. That's such short duration. And I got it, maybe the GMC also has its own process of evaluating, and then they got back to me on 9th of May. So yeah, this is the journey, I think, in summary.
Good. Congratulations again. Really well done. Of course, I've got lots of follow-up questions, but I know you said that there's some things in the evaluation form that provided you good insight. So happy for you to take the lead and tell us a bit more about the whole evaluation form and what it's stated. Of course, be careful about the GDPR side of things. But sure. Tell us some highlights of the evaluation form that you would want to.
One thing good about the evaluation form is that, the feedback which you get is quite not just saying that you have done this well, you've done this part well, but they also do provide constructive feedback. So for example, one of the constructive feedback I got was that, because what I did is I considered the specialty specific guidance as something like like a Bible.
The Holy Grail. Yeah.
And in that, if you see, the 2022 curriculum says that 2 cases need to have a detailed physical examination. And as a psychiatrist, I thought, okay, 2 cases. So in mine, for the inpatient, I did a detailed physical examination, but for the community patients, I didn't do much of physical examination. And that was pointed out. They said that, look, this is good. You have submitted it. You have identified so many things, but what about the physical examination part? We want relevant physical examination to be a part of your GP letters. But they said that, however, as you have done it in many other case reports, we consider this as, we let you go. And so that was something which I felt is quite important. And that was something, if I knew, I would definitely have done it. But because you are so stuck with, specialty specific guidance, we forget that it's the relevant physical examination they're looking at, not something, like a typical, proper, perfect case history, but that. The other thing was that, my tribunal reports, they said that, they had timeline of my tribunal reports. They said over a period of time, after you attended few tribunal courses and things like that, your report quality started improving. And they said the last 2 CTO reports which you did in the community and presented evidence was quite good. So that was actually really nice to know that, they sit with the timeline, they see how the candidate has progressed through these. For me, it's more or less 3 years, from October 2020 to October 2024. How did he progress? So those 2 I felt was quite good. And I would say that is something which many might miss. That, my reflection on that was each case history should have a nice flow. For example, if there is something in the history of presenting illness and if something in the childhood history, then that should be represented in your descriptive summary, psychiatric formulation, your diagnosis. And relevant to it, there must be a physical examination. Relevant to it, there must be investigations. And your treatment plan should also have something relevant to it. So that proper connection and flow should be there is what was my reflection on the evaluation form which I got. And the other thing is that the focus of the form, again, this is another reflection, is that the focus is HLO2. And the focus is HLO2 connecting to the other HLOs, like HLO3, which is the mental health act related work, HLO4, which is the health promotion, HLO5 and 6 related to teamwork, leadership, safeguarding. This has to be connected. And the main focus is HLO2. The most critical points, the big paragraphs which I got was in the HLO2. So I would say, like others have previously mentioned in your podcast, because I've seen many. So that's the main bit. I would again say focus on your cases is my takeaway point.
True. With regards to your fellowship, were you placed in different settings as a part of your fellowship, or were you?
Yeah, so when I was as part of the initial psychiatry fellowship, it is a 3-year program. So the first 12 months I spent in the inpatient. The next 12 months was in the community. Initially I was asked to work with the assessment team for 3 months, and then my clinical supervisor had a discussion with me that okay, you can work a bit more independently, and I was given the responsibility of working under a consultant in community. And then I requested for early intervention in psychosis. And the supervisor there was quite happy to have me and started giving me cases. Initially I was shadowing, and then I started seeing patients independently. So yes, but midway, as I said, I shifted to CESR fellowship program. In the CESR fellowship program, it was, of course, the service provision is the main thing, but they did value things like, if I wanted something, they said, okay, I think you can continue with, you can leave the assessment team, because I had done 2 cases from the assessment team as part of and I felt I need to do a long-term follow-up of patients. And to do that, I have to have my own caseload in both EIP as well as with the community. And they did agree to it. And luckily for me, because I had already collected my inpatient evidence, thanks to my consultant with whom I was working back then, literally handholding was something they did to me when I initially started. So that was already collected for me. So I had collected around 6 inpatient cases where I had presented, I had written the tribunal report, presented the evidence, and tried to link it with teamwork and safeguarding and things like that. So this way, so there is a clear-cut structure in the fellowship program. And again, when I changed over to CESR fellowship as well, there was a clear-cut structure for me.
I see. So as a part of your CESR, like a lot of, I've seen 2 sort of different schools of thought, and I think belong to the second school of thought, where I've worked with a lot of CESR aspirants, worked with a lot of CESR fellowships, where people are rotated in different placements every 3 months or every 6 months. And there's this rigid structure where people are moved around, which is well and good, if the candidate collects all that evidence during that time. I didn't have a structured fellowship program when I did CESR. However, the 2.5 SPAs that I had, I would keep moving within the trust. I used to work in a smaller trust before the one that I did my CESR in. So everything was much more approachable. And you could go in the crisis team office, you could ask for a couple of assessments, you could go in the inpatients and say that, look, you know what, I want to shadow this this patient, and hence the inpatient clerking, the rounds, everything that you do, make sure that you involve me, and they would be able to happily accommodate as well. So were you rotated during your CESR fellowship, or were you placed with the EIP and community?
I was placed with the EIP and community, and I did rotation as you did in my 2 PAs. So, but I for me, what was happening is my supervisors were contacting the crisis team and saying, this is a candidate who's coming, and please, these are his requirements. So they already knew what I wanted. And for me, it was also a bit more than, just the crisis and inpatient. For me, it was also, I had to explain things to the child psychiatry department. I had to explain things to old age. And again, they were quite helpful, I must say that. And, when you collect a child psychiatry case, it's slightly different. There's a different format. When you do an old age, again, there's slightly different. And both were quite accommodative. They looked at my report. They said, these are the things which you need to change. Even the old age psychiatrist told me things like, let's have a case-based discussion. We'll attach that form. Maybe it'll help you with your evidence. The child psychiatrist told, this is a very interesting case you have written. Why don't you present it to the team? So that again added to me working as an MDT, and I added even that. And he even gave feedback. So in that way, yeah, I had my protected time, which was quite fixed, and it was not even, it was a part of my job plan. There was no interference with that. So I used that to collect child psychiatry, old age psychiatry, ECT, and a few of the, Section 12 related urgent assessments and things like that.
Right. I see. So 2022, you entered into the CESR fellowship
Early.
Early. And during the time period between when you entered the CESR fellowship till when you ended and submitted, you were working with the same team. Your time was split between EIP and community.
Yeah. I didn't change.
And did you do your Section 12 or AC?
I did my Section 12 when I was in the inpatient itself. So I had completed it by the time I came to the community.
By the time and that's roughly, give me a timeline on that.
So you need to be in UK for 12 months.
Yeah.
So I think got it in November 2021 or December 2021 during that period. This one.
So roughly about
Section
a year
12.
after you moved.
Yeah. And it's a mandatory thing. You need to have. But if you have an MRC Psych, it's, I think you can directly get 3 months.
Yeah. So I in fact, like you said, a lot of people choose. So I had two options. When I came from India, I had two options as to I could have either entered into the higher training pathway or, but the thing with the trust that I worked for at that time, and I still love and care for that trust really, really deeply. I got along really well with Navigo, and I knew them for about 2 years before I moved. So I wanted to work with them, and they didn't have a higher training scheme. And I said that, look, I have MRC Psych, and I would love to work with you if you provide me the support with CESR. And they're like, whatever you need.
Nice.
And like you say, the trust was just really nice, really kind. All the consultants there, couldn't thank them enough. My medical director, can't thank him enough. They were always so supportive. Yeah. And I think a supportive trust plays a massive, massive role in anyone achieving CESR. If anyone says that, I've done CESR despite my trust, no, it doesn't work that way. You need to have the support of the whole team and the trust.
Yeah. I'll definitely agree with you. I mean, the amount of support I have got is quite high. In fact, I even had a supervision on May 3rd. Because I got my result on May 9th, I was discussing 2 cases which I thought I'll prepare it in case my application comes back. So, I mean, without their support, for me at least, because what happens is that the main area where I felt their support matters a lot is, it's an uncertainty when you submit for CESR, the case histories, the GP letters which you're submitting. You never know what it is. But if you have a tutor, if you have CESR evaluators as tutors, it would give you, they would look at it and they would say, no, Sharath, this one, I don't think. You need to add few things. And some they would say, go on. It looks good. So that gives a bit of confidence. And I think that is very important because otherwise we will be submitting evidence which we, from the bottom of our heart, feel like, yes, this is right. But it might not match with what the specialty specific guidance is or the evaluators are looking for. So in that way, a lot of support and quite happy as well.
Good. I think thank you for the initial information. I think that helps us paint a picture that through those 2 years, you were working consistently on the same team and had
True.
a caseload, used those 2.5, 3 PS, that however many you had in the job plan to be able to focus and move around. Now, tell us a bit more about the child and adolescent and older people's evidence that you gathered. So, by and large, I think you had to submit, say, roughly 30 case histories, right?
So 30 cases from general adult psychiatry.
General adult, okay.
And then
how
I
many
had
did
to
you submit from child and older people?
So 2 cases from child and adolescent psychiatry and 2 from old age.
Okay.
And the 2 from child and adolescent, one I submitted with help from the ADHD, and the other one I submitted was from the childhood emotional disorders. So 2 cases from there. For each case, for one I did a case-based discussion with the child psychiatrist. For the other, I did a case presentation to the team, and again got feedback from them. And for old age psychiatry, it was an inpatient. I did my old age psychiatry. For child, I did it in community. So for old age psychiatry, I went to the inpatient, which was a combination of physical and dementia, mood disorder kind of a ward. And so it had to be something like, it should not be like I just go there because I'm collecting evidence. So it should be like, this is a case which we were planning to discharge, but there's been a deterioration. Can you do a detailed workup? So I got an email, and he advised that these 2 cases are something which I need more information on. So I collected that case. I put it on for the team to say that, this is my detailed workup and this is my formulation plan. And then I had a case-based discussion about it with the old age consultant. So in this way, I think it took 1 month in child and 1 month in old age to get 2 cases.
I see. Okay. So for the older people's one, you submitted your formulation which you had prepared over the time that you'd spent with the patients there. With the CAMS one, did you do independent clinics, or how did that work then?
So
what evidence besides the WPBS did you submit?
Also the independent letters which I wrote. And
that's
what
GP
I did,
letters.
Yeah, the GP letters. And
okay.
I think what I did for the CAMS was for the CAMS was that I think I put it on the Rio notes. We have our Rio notes, and I said that this is the detailed formulation I've done. And I don't think I sent a GP letter for child psychiatry. It was a detailed formulation for the team and an MDT discussion with the team, which I had put on the Rio notes. And yes, I did independent work along with ADHD practitioners for the collection of evidence.
So essentially your formulation or notes, which were quite detailed and would evidence the fact that you've taken a detailed history of the patient and you know what you're doing with. Because I completely understand that with CAMS and older people's in a general adult portfolio, they wouldn't expect very, very detailed things, but they would want to know that you're a safe practitioner. So I suppose they would want to know whether you know how to establish rapport, whether you know, because as a consultant, you will, when you do on-calls, you will be doing on-calls across the board. So it's those cases of emergencies that they want to hopefully make sure that you're not doing any gross mistakes or problems with. Okay, so these
and just to add to that, the evidence which the evaluators are looking for in CAMS and old age is at a CT3 level, not at a ST6 level. So, and in my case-based discussion form, I had sent them a CT3 form. Because I had a pre-membership training portfolio with the Royal College. I'd sent them a CT3 form, and I'd asked them that if you feel I work above the level of CT3, please do mention it in your detailed feedback. And they had put it that he's working at a level above what a code trainee I would expect, and things like that. So even that I think is something we need to be mindful of.
Okay, good. With regards to say the psychology evidence, let's move to the psychology evidence and tell us or walk us through what evidence you provided and how did that work.
So for psychology, one case which I submitted was from CBT, 12 sessions. And along with this 12 sessions, of course, the 12 session notes I submitted, and I submitted the discharge letter to the patient, which I wrote and summarized, what all we did in these 12 sessions. And then I submitted a SAPE and a PACE. So this much I did for one case.
I see. And the other one was?
Other one was psychodynamic psychotherapy.
Okay.
For this case, I did 42 sessions with the client. So not all, but things where there was something something related to the unconscious mind, which was very good. And those session notes I put. So around 10 session notes out of the 42. And my letter to the patient, discharge letter to the patient, explaining what happened in all those 42 sessions, a good summary. I submitted a mid SAPE, which was like a midway review of my progress with the client, and then a final SAPE and a final PACE. And my supervision notes with my psychotherapist.
Okay. And so for both these, you were supervised by the psychotherapist?
Yeah, for both.
Okay.
And it was all arranged by the trust.
Good. No, that's really good. And for your general adult, how did you sort of mix and match the A, inpatient evidence, B, community evidence, and what sort of different diagnoses did you give?
I mean, in terms of, let's start from inpatient. So inpatient, it was, I submitted around 12 cases. 6 cases. And in inpatient, I submitted the tribunal reports mainly as the main bulk of what evidence it's going to be. And then, of course, the MDT notes. Important MDT notes where there's evidence that I have chaired the session, where there's evidence that I have collected collateral information from the family members, and where there is evidence that I have done a physical examination with the patient, and evidence of me having discussions with the Cumberland Infirmary with regard to what's happening with the client, how to go about, and also few email exchanges between me and the team members, where I have contacted the Ministry of Justice and provided all that kind of things. So this is what, and the cases were predominantly, severe disorders, bipolar affective disorders, and schizoaffective, schizophrenia, and one or two maybe having traits of, personality, cluster B personality as well. So this was predominant from the inpatient. And
now, just a sec. With regards to physical examination, how did you evidence that?
So physical examination, I had to evidence it again because I felt that core training competency does come as a part of it. So what I did was I started doing ECGs and taking bloods and doing the initial clock-in of the patients. And I asked the associate specialist in our ward to complete something called as DOPS, which is direct observation of procedural skills.
Right. Good.
And
that's a good way to sort of evidence it.
Yeah. And the other thing was I also had to evidence my history taking abilities, my mental state examination abilities as well. So for that, I submitted ACE, Assessment of Clinical Expertise, in a way that it's a part of my 6 inpatient cases. So it is added to that.
And you did full ACE, not mini ACE?
No, full ACE. Yeah.
Good. That's smart. Yeah. Okay. Go on then. Then inpatient 6 cases. What else?
Then, of course, the community. The community patients. Again, the community, I divided them as patients from the assessment team.
Assessment is crisis, right? Or
no, assessment is the initial assessment for any patient who comes into the team. So we have an assessment team. And if in the assessment team, the reason why I worked with assessment team was that, it will give me the opportunity to see the patient for the first time after a GP referral.
Okay, so it's like a triage team. You've got a whole triage team then.
Yeah.
Oh, that's interesting.
And I work for both assessment team of the community mainly, and even if they have any complicated case in EIP where they felt they need diagnostic clarification and things like that, I did the initial assessment with them as well.
I see.
So few cases from there. I don't know how many. I would say maybe 4 or 5 cases from this part. In this part, it is like I see the patient once, I call the patient again back, I formulate a plan. Okay, this patient needs this kind of, let's say he needs mood on track or he needs group therapy. Then I contact the clinical lead of the psychology team and send them an email saying, I've done this. Please look at my detailed evaluation. He may need this. If you want to discuss further, we'll have a discussion. So maximum 2 sessions with the patient, then bulk of discussion with the our team, and that was something which I submitted as for 4 or 5 cases probably.
Got it. And anything else besides these 2?
After this, of course, working with the community team, what happens in our place, we divide as per patches. So under me, there is 3 GP surgeries which I work, and I have an associate specialist to supervise me, and I have my own caseload. So here what I did is, these are the cases which I did a follow-up. So I think around 10 cases here, which I did a follow-up for at least a minimum period of 9 months. And what I thought was, which was an idea which was given by my CESR tutor, that what you do is, because you have done a follow-up for more than 9 months or 1 year, give a detailed, comprehensive summary of your work to the GP.
Yeah.
Otherwise, what will happen, the GP, if he gets letters which are 12 pages, he'll be like, what is this? How is it going to be even helpful? And because CESR requires primary evidence, I thought, giving a comprehensive summary to the GP, giving a comprehensive summary to the team was a way of completing, there must be few cases where you do a full follow-up of the patient.
Yeah.
And in this, I also did assessment. Then it was from my GP patch. I saw them, and then I did a discharge summary. So that completed the entire journey as well. So few cases were entire journey. Few cases were a complexity and uncertainty. So we are still with the patient. And this is one thing. And the rest of the cases, I collected from EIP. So in EIP, I focused on, of course, the main thing was first episode psychosis and bipolar disorders. In the community, my focus was personality disorders, major depressive disorders, and of course, anxiety spectrum. So the cases which I selected also had discussions where, I have discussions with the regional affective disorder services to find a good treatment plan because I'm stuck. That again adds a bit of safeguarding discussion with safeguarding lead to cover MAPA meetings, which, I attended for few of my patients. For 2 or 3 of my patients, I also had to attend after action review meetings as well. So again, that helped reflection, discussion with the MDT team that I have attended this. All those things became part of, my case. And as part of transcultural psychiatry, I also had many patients who were, immigrants and who were having psychosis and use of translators in, taking the history, identifying the cultural difference and things like that. So 2 or 3 cases were of that background as well. And 1 or 2 cases from, having a different sexual orientation and how did I manage that? How did I help them and things like that. So even that was some cases which I had in my portfolio.
Interesting.
So, yeah,
go on, sorry.
No, as I said, I thought it should be a complete ICD-10 involvement. So even eating disorder was something which I had few cases because some of my cases from my GP patch were under the eating disorder team. So I thought, okay, I'll involve with them and ask them, can I do a workup and have a discussion with practitioners working with the eating disorder. So even that was part. So in this way, yeah. And in between this, if a patient because it's a 9 months, 12 months journey, and some of the cases were in the waiting list of care coordination or SCM. And of course, whenever there's a crisis, I used to tell, if it is from my patch, I'll be the first to respond to it. So 2 or 3 cases where I saw them and I said, this case I need to do a medical recommendation urgently, a discussion with urgent care team, AMP involvement. That again covered my crisis, kind of requirement.
Yeah.
And I used a bit of Section 12 work, which I did in the Cumberland Infirmary, accident and emergency, as part of liaison. Because few cases also, they expect that, it has to do with physical health and with infirmary kind of a thing. So even that helped.
Good.
So I think brief summary of...
I think I'll highlight a couple of things that are common roadblocks that a lot of people do wrong, which we haven't explicitly mentioned in this summary, but I'd like to highlight that really, really strongly and commend you on that. One is the diversification of evidence. Like, I think a lot of people, like whenever I used to and whenever you listen to Dr. Nandini Chakrabarti, she keeps saying the CESR mindedness thing. And the fact that whenever you're thinking, you should think of it from the CESR perspective. And I think that reflects really brilliantly in your evidence when you look at it from a global perspective. Even though you didn't have so-called CESR rotations, you've got a good chunk of general adult inpatient, a good chunk of outpatient, good chunk of crisis experience, and hence an evaluator, when they evaluate your portfolio, they're seeing that, okay, he knows how to manage a patient in a community, he knows how to follow these patients up in the community as well, he knows how to, if raised concerns or raised alarms, he knows how to signpost it to the AMP, signpost it to the crisis team, and if by any chance he ends up working in inpatients as a consultant, then he also knows how to manage patients inpatients, because you've then also submitted your inpatient clerking, your physical examination, all that good chunk of evidence as well. I think what's also massively important is this diversification, not only in the population, that the evidence that you're presenting, but also in the diagnosis that you're presenting. And that was a conscious decision, like you say, that you need to have something from all the different parts of ICD. So you've submitted mood disorders, you've submitted, psychotic disorders, you've submitted eating disorders, which is all really nice and good. Even the psychology evidence, the fact that you this is something that a lot of people will end up asked me, and now that you've got it, will end up asking you, is how do you manage the psychology evidence? And I think the way you did it was brilliant. Absolutely. CBT and psychodynamic, both comprehensive, 12 and 42 sessions, presenting summaries, presenting discharge letters. I think what was also very, very good is the fact that you followed up patients in the community over 9 months. So what I did was I submitted frequent GP letters. So every time I didn't submit only one GP letter for one patient. If I've seen the patient over, say, 9 months, 12 months, I would have submitted all those 3-4 GP letters, which would present all that evidence. And like you did a GP summary, I presented it in the reflections that I did. So there would be a workplace-based assessment, but the reflection would also suggest that, look, I initially tried aripiprazole, that didn't work, or that, showed some akathisia, so we moved to secotiapine, and then we gradually tapered up the dose. And that is how, so that tells the evaluator that what are you basing your treatment decisions on, how you're constantly following those things up. Interesting.
I mean, just to add to that, when it comes to reflection, I think I've reflected to all the cases, all the 30 cases. I think
absolutely.
I did a reflection. Predominantly, one, I think it's my way of communicating with the evaluators in case because I'm not there. They're evaluating something which I cannot defend. So I thought, let me say that this is what I learned. This was my experience, and I used to point it out that this is like a crisis assessment. This is where in the MAPA meeting I highlighted it in case if they miss, because you're submitting so many pages. In case they miss, they will look at the reflection and do it. The other thing which I did differently was I put a summary statement for all the HLOs. So 1 or 2 pages of summary statement as to what I'm doing. So for example, if I'm submitting case 1 to case 36 in my case, because two child, two old age, and two psychology cases. So total 36 cases. I put in a page where I said, this is the case, this is the diagnosis, this is the age, this is the religious diversity or sexual diversity which is there, and these are the HLOs I'm targeting.
Yeah.
As a table for all the 36 cases, in case if they feel okay, he has mentioned this, if let's see whether it's really there. So, and a reflection to all the case, just to make sure that they identified. I think summary statements will be very helpful for safeguarding, because I did a reflection and a summary statement saying that I do not know what a risk assessment is or what safeguarding is, because I was working in a country where it was not that given prominence. And I told them that I learned it by doing these level 3 trainings in child and adult safeguarding. I attended this HCR 20, which again enhanced my knowledge on how to do safeguarding. Had a lot of discussion with safeguarding leads. So that again will tell that, okay, this guy is progressing over a period of these years. And so I think summary statements for each HLO can be helpful.
Yeah, absolutely. I think I'll just add and amplify that point by essentially saying that what I did was, like you said, the SSG or the specialty specific guidance is your holy grail. So if you look at that curriculum document, they've got I submitted mine based on ILOs, right? Now there's got ILO A, one will have 1A, 1B, 1C. So, and then they will put the workplace based assessment, which is for each ILO. What I did was, I was that obsessive, is that next to this, I submitted my evidence. So there was, as a part of my CV, as the initial cover letter, so as to say, for my CESR portfolio, there was a whole mapping of evidence document, which had not only each ILO, but each sub-ILO, and what was the evidence that I had submitted here instead of this. And like you say, with each piece of evidence, whether it be a case summary or whether it was chairing a meeting or whether it was a chain of emails that I had attached, my reflection would have the ILOs that I'm evidencing in this piece of evidence.
True.
So what ILOs are relevant to this piece of evidence and what I'm trying to evidence. And then in the third section of the reflection, I would say two things: diagnosis and management. So I would talk essentially to the evaluator and tell him or her what I'm thinking as far as the diagnosis is concerned and what I'm thinking as far as management is concerned. So guys, do not see reflections as a formality. A lot of people feel like, oh, why do I have to produce reflections when I've already done everything? Well, the reflection is your only way you can talk to the evaluator. There's no other way. Your GP letters will be directed towards your GPs. Your MDT meeting minutes will be directed towards your colleagues. Your referral letters will be directed towards all the other professionals. Your email communication will be directed towards the problem. Whereas your reflection is the only way you get to talk to the evaluator and tell them that, look, I know that you want me to evidence this ILO. This is how I'm evidencing this, and this is the thing that I was thinking. Why I chose, say, fluoxetine instead of paroxetine, or why I chose whatever medication I chose. So look at it from the perspective of an opportunity rather than a formality that you have to get through. And if your reflections and your HLO2 or your case summaries are strong, people have, like, I've heard every CESR evaluator say this, that if your case summaries and your case histories are strong and ironclad, then there is a lot of leeway in all the other things which, as a consultant, you might not need to be an expert in. Even if your psychology evidence is a little on the weaker side, but your case summaries are really, really strong, that's the way to go.
I mean, I would agree with the last point, definitely. Because, as I said in my evaluation form, the chunk of writing is in the HLO2. And the others, they have just mentioned, this is the evidence, he has fulfilled. This is the evidence, he has fulfilled. So if the HLO2 is hitting all the points, then yes, it would be very correct what you said.
Brilliant. Absolutely. Any other things that you would want to highlight, Sharath?
The other thing I would highlight is something called triangulation of evidence, which we have already spoken, but I think it's an art. You will not know it in the first 1 year of your I would say CESR fellowship, but for others, in your journey of CESR. And this is something where the CESR evaluators or the CESR tutors really helped me. They were seeing my letters. They were saying, okay, there's this letter. and you've mentioned this, that you had some kind of a discussion with your associate specialist. Why don't you have an evidence in the form of an email? So I was deliberately like putting my case report, sending it to my associate specialist or sending it to the GP, asking them like, I have sent this. What do you think of the comprehensive summary? They would get back to me. Correspondence would be a good way. I would always be behind the admin that, I want the minutes of MDT. I want the minutes of after action review immediately. And I would immediately anonymize it and keep it ready. And once you have triangulated evidence and added a reflection to it and completed the case, keep it aside so that you don't think about it again. If you do only a GP letter and say, okay, I'll do the triangulation later, you will just be ruminating on a single case and you won't move for other cases. So I think it's quite important that, when you're seeing a case, from the initial phase itself, see the case that, okay, this case I'm going to use for my CESR. Then I also have to look at triangulation of this case. So that is the way I feel if you approach, the time frame required can reduce significantly.
Absolutely.
Yeah.
Yeah, I think help paint a picture, I think, is the way to go. The way I sort of thought of it was, because when someone's seeing it, put yourself in the evaluator's shoes and say that, look, this is a brilliant case summary, but it's like 4 pages of brilliance without any other thing, without any other documentation above it. Whereas this is an above average piece of evidence, but then there's like emails to follow it up, or then there's GP letters as well, and then there's these minutes of meeting as well, and then there's this referral that he's done to psychology as well, and then there are these physical investigations that were attached because he communicated with the GP and asked him to do bloods and ECG. That tells me that it's a real case.
True.
You're not making these cases up.
And it will cover all the HLOs, like you said. Teamwork and leadership came there. Correspondence with physical examination, health promotion came there. So, you're right. And it tells that you're real. And I would say don't go in search of a perfect case, because that doesn't exist. And I feel that, they look at yours, they'll say that there is constructive feedback, as I got. In some of my complex cases, they said, 2.3. HLO 2.3 is complex and uncertainty, because your ILO, intended learning, in the higher learning outcome, there's 2.3, which is complexity and uncertainty. So they put there are cases which he has submitted which are so complex and the treatment is so uncertain, but he has hit it because it's complex and uncertain. So I would say if you go behind, like, I need to show them a perfect case because I'm not there present physically, then it would take a lot of time and you wouldn't be able to achieve it. So
absolutely. I think I said this during Dr. Nandini Chakrabarty's podcast as well, and I'll repeat it right now as well. Sharath wouldn't have sat and tried to learn the names on the numbers of the HLOs, but you need to be so engrossed in the CESR thing that you should know each HLO by the tip of your tongue, that with this I'm evidencing this, with this I'm evidencing. That's how CESR minded you need to be able to get there. But if you do, you'll get there. Like it will come. And now, whenever anyone talks to you about a piece of evidence, you'll be able to say that, okay, you're evidencing this and this and this. But you need to. The word that I used was implicit memory. It should be in your implicit memory, not your explicit memory. Your HLOs shouldn't be like a rote memory thing where you know what they are. You should be able to apply them in your clinical evidence. And once you get there, then it will become much more easier. And always do remember that the people who are evaluating these portfolios are very, very experienced psychiatrists. They don't expect you to be a magician, but they don't really like being patronized to or lied to as well. And if That's you do sort of make cases up, it will be evident. Whereas if you show an imperfect case where you're working with the patient to get some improvement,
I agree.
Then that's all we need.
I mean, I'll definitely agree. I would say, the first 6 months to 12 months in the journey, it's really difficult. You may, because I was having tutors, I used to send them and they were like, Sharath, this needs work. Sorry, this needs more. And it can be frustrating, but it takes time to know specialty specific guidance. It takes time to know how to write a detailed case report. With time, it will be easy. And by the second or third year, you will be in that, your mind would have tuned to it. your typing speed would increase, all that things will happen. So the other thing which I wanted to tell was definitely the computer skills is very, very, very important. I would say please do learn anonymization on Adobe, how to anonymize a Word document, how to convert Word documents to PDF, pay money for subscription. It's worth it. Get it done. And otherwise, what happens is that, you get stuck in things which are not under your control, and you'll be frustrated a lot. So prepare for that computer skill aspect as well.
Absolutely, 100%. I would strongly advocate for this, that stop cheaping out as far as buying some subscriptions is concerned. Use your study budget, or if you can, or buy them out of your own pocket if need be. But as far as the things which you can automate, the things wherever technology can help you reduce your effort and time and energy, don't cheap out. The more paths of, make it the easiest thing to do for you to get anonymization done. Use admin time. Make sure that you've got really good relationships with your team members, your admins, so that they can help you out. Buy these subscriptions, because like right now you would think that why should I invest, and this is all really costly. But imagine the difference in salaries that you will have, and within like 15 days of the money that you make, you will be making up for all these things. So don't cheap out, guys, on purchasing subscriptions and these things, because they are more than pay for themselves.
And just another piece of advice from my own is, please don't submit your entire portfolio as one PDF. That would be a big mistake. Subdivide it into 36 cases, divide it and put it, because if it comes back that you have not anonymized, it will be like you have to again remove everything. Just to add a document, it would be very difficult. So I would say, because a few of the other friends of mine who did do that, and it will invariably come back saying that, the orientation is not right, you need to change, or you have not removed the names of one of the patient in, somewhere in your entire portfolio. So don't submit entire thing as one PDF. Divide it, submit it as PDF, separate ones.
Absolutely. Even when, like in your case, you submitted all or most of your evidence from one organization. In my case, there were 3. So as it is, you will have to change your PDFs, because every page that you submit from a particular organization will have to be authorized and verified by the referee from that organization. So the referee will get a form which will say that, look, these are the 12 documents or 15 documents. There are 12 pages or 15 pages in document 1. This is the name of the document. This is document 2. These are the number of pages. This is document 3. These are the number of pages. And they will get some of that evidence sent to them via email by the GMC as well. So
you're right.
Of course, like you don't need to, if 36 case histories, what I did was I split them into 4 PDFs, 10, 10, 10 and 6. But you can modify and check and chunk and make sure that everything is not in one PDF, because then editing it, opening up files in our slow work laptops is also going to, reduce those things. Don't micro cut it into really small sizes, but at the same time don't put everything into one file. And make sure that all this evidence is very tip of your tongue. You know where your evidence is. Like all your case histories from one organization can be in one folder. Case histories from the second organization can be in second folder. Minutes of meeting can be in third folder. And what I did was I did that retrospectively. And the GMC told me that you don't need to do it massively, because they'll reorganize it for their own sake and for the evaluator's sake. But I number coded the documents as well. MT2, MT is my initials. MT2 was case histories 1 to 10. MT15 was minutes of meeting, or MT17 was email communications. So I know where these things are on my laptop as well. And they help me organize and identify those documents. And then when I'm preparing that form to be able to send it over to the referees as well, I know what documents I'm sending and how many pages these documents are. So there's this admin side of things besides the the psychiatry side of things. Like he's saying, the computer expert or the computer at least working knowledge side of things. Try and make things as easy for you as, use your own organization system to be able to have that ease of use.
It really helps, just go for the subscription, get it done. And if there is a group of CESR fellows, the subscription can be used by others as well. One thing I would I had 2 points, in fact. One is, I was quite lucky. Others might not be. The verifier you select is going to have to verify your entire document. What I did is I sent everything, some 10 days before my submission. And I'm very thankful to my verifier. She sat the whole night and did the verification, checked it in the Rio notes, and is the GP letter there in the point, and then she approved it. I would say please don't subject them to that. As and when you are ready, if you have a supervisor, if you have an educational supervisor, tell them to, if you have selected a verifier, tell them to do it as and when, so that, they don't get overwhelmed with so much.
It's always going to be more difficult to go back and verify an evidence or produce an evidence than it is going to be. So always try and work prospectively rather than retrospectively. If you've already done a case and you feel that, oh, now I want to go back and use it for CESR, you can still do that. But remember that it will be slightly more difficult than, just working with a new case and just getting a new case summary done and making sure that all the evidence that you're prospectively creating is good.
Yeah. True. The second point was, we all need that emotional support. And I would say, because I was in a CESR fellowship program and we have others who have submitted, who have got it, that actually helps. We have meetings once every 3 to 6 months for one day where we go. We have peer group meetings where we, discuss things. It does help. So if there is an opportunity to be a part of a fellowship program, my advice would be, please use that opportunity within the trust and be a part of it. Because emotional support really matters. Because I took around 7 or 8 days just to submit my form, and I was exhausted. And I was calling the other fellows, like, how about this? They were like, don't worry, this is what I did. You do this. So that quick fix is something you do get. So yeah.
Yeah, absolutely. I think it's good you had this support. I didn't have a CESR fellowship program, like I said, or I didn't have any precedence of people having done CESR, but I had the emotional support in the form of my medical director, my colleagues, my peers, my friends within the trust who, would always back me up. And that's not only the doctors, even my medical staffing, my admin team were rooting, and, these are the people that you just can't stop, and you have to call them the day you get that email to thank them and say that, look, thank you so much for, always being out there for me.
True. I mean, I remember when on Thursday I got it. I mean, I shared the room with another specialty doctor, and the consultant sits in the next room. And when it came, we were like shouting and we were like jumping, and then the consultant, what's happening? And she had to come to our room to check what's. So yeah, it is worth every penny. And yeah, I mean, the family support also. I mean, I don't know if I have to say, but I'm inherently a bit of an anxious, ruminating kind of person. And yeah, I put in a lot of, projection on my better half. And 7 months of projection is no joke. So she's quite a sponge, I would say. So yeah.
Good. Finally, tell us all the names of the people that you'd like to thank before we end this, because I think all the people who stand for you, stand with you in this whole process, deserve as much congratulations, thanks, blessings and wishes as much as you do.
Yeah, because I think no
one can do this.
Yeah, I think I'll start from my fellowship program. So there'll be a lot. So if you get bored, I'm really sorry.
We've got all the patience.
So of course I would like to thank the director of the Psychiatry Fellowship Program, Dr. Neeraj Berry, and the medical director, Dr. Rajesh Natkarni. They were the ones who selected me for this fellowship program. So really, I do thank them from bottom of my heart. And my educational supervisor during my fellowship program, Dr. Roger Cable, he was an old age consultant, again helped me with old age psychiatry evidence collection. I do thank him. My inpatient consultant and associate specialists, Dr. Sharmila Menon and Dr. Hashim Zaini. Very helpful, literal hand-holding when I had no idea what NHS was or how to work. Forget about PQ, I didn't know how to work in an acute inpatient, so I thank them. My CESR education evaluators, Dr. Adrian Lloyd, Dr. Josie Quinn, and my clinical supervisor, my verifier, my everything is Dr. Annika Muller, who helped me, submit the evidence on time. Also, who wrote my structured clinical report, the consultants who work alongside and who supervise me, Dr. Alison Ferguson, Associate Specialist Dr. Judith Whiteley, very helpful. And of course, my CESR fellows with whom I've had good interaction. Dr. Depot, I must thank him personally. He helped me, with how to get a structured clinical report from medical director, whom to contact for ECP, training, and also with critical appraisal, how to use CASP tool and things like that. So he was quite helpful. And of course, during the submission time, he was there. Others from the CESR fellow group, 6 members, again, I thank them a lot. Of course, my wife, Aarti, I must thank her for being that sponge, for observing my projections and being there for me. So thank you all. Yeah.
Good. Well, congratulations to you and all of you. And this is just to also highlight that CESR is not a one-man effort.
No.
As much as, people put in and say that, it is a team effort, and it will genuinely need to be a team effort. So the leadership management and teamwork evidence is not just for the heck of it. It is actually that. Thank you so much, Sharath.
Thank you.
I think we'll try and get back together again if we come back with a lot of questions that people might have. But thank you so much for sparing the time to do this, and congratulations.
And thank you, Dr. Manan, for giving me this opportunity. I thought I would literally fumble, but thanks for arranging it. And I think this is kind of closure to me. All the things I've said. I'm hoping this is helpful to other candidates as well. Thank you. Thanks for this opportunity.
Absolutely. It is cathartic. That's one of the main reasons why I do it, and I keep in touch, because CESR absolutely changes your life. It also teaches you in a way as to how important teamwork is.
True.
And to make sure that once you've done CESR, or once you're in the process of CESR, you realize that how important it is to respect, manage your expectations and emotions with your colleagues, with the people that you work with. And unless you don't do that, unless you don't master that, you'll not be able to sort of get CESR in the first place.
True.
So there is a lot of non-psychiatry element to CESR, which is not really verbalized, but once you do it, you'll know that you need that.
No, I do agree. Every word of it, yeah.
Fabulous. I'll see you soon, and thank you and congratulations again.
Thank you. Thanks a lot.